good value-based payment model, you have patients not coming to the ER for non-emergent circumstances, but the value-based model has figured out a way to get those folks into advanced integrated primary care. You have found a way to connect the behavioral health component in a way where a provider is not struggling outside their area of discipline. You have found a way to ensure that there is support when patients are discharged so that they don't represent. So you're basically trying to provide the provider with the best information and ability so that there is more outcome-focused, evidence-focused ability to treat. When it works, it's exciting. And I think when it works, it can be highly efficient. The question simply becomes, is that really what these models can look like, and can they be really supported so that folks see the value of working smart?
We have a system where we spend 50% of our resources on 5% of the patients. If we're spending 50% of our resources on 5% of the patients and we want to generate savings in that system, we'd better focus on that 5%. And that 5% are highly complex. They're the multi-condition, comorbid patient, has behavioral health issues, physical health issues, chronic conditions, expensive medications. That's where our expense is happening in the system. The reality of value-based payments and the value-based payment structure is that if it's successful, we are utilized less. And that becomes a challenge if your mentality as a hospital is still heads in beds. If your focus is we need to fill the beds, then you're still thinking in a fee-for-service mentality.
So in the ambulatory care space, primary care, specialty care, we're hearing a lot from both hospital-owned, hospital-affiliated, medical groups, practices, as well as community-based practices around value-based payment. A lot of people don't really know where the puck is going or how quickly the puck is getting there, and how ready should they be for that value-based payment. But we all do know that we have to move from volume-based payment to that value-based payment. And the biggest thing that we can say right now is, how ready should we be? What should we be ready with? And those are the things that we're hearing as concerns with practices around their patient populations. One of the things is attributions. What patients are being attributed to them, how many lives are they responsible for, and how does that impact their opportunity to participate in value-based payment?
One payer may have one set of measures, and the government has a different set of measures, and depending on whether it's state or federal, and special arrangements that they may have, there may be still another set of measures. And although the themes on these measures often are familiar, there are subtle differences in what is being measured and the time frames, and quite frankly, it's extremely confusing and burdensome to our providers who are just simply trying to take care of patients.
My constituents are the fiscal officers in hospitals, and so typically we'll hear, can we do it from a fiscal perspective? And I think the challenge that they feel is with Medicaid paying at 73 cents on the dollar for care, for Medicare paying at 93 cents, right? How do you make this work from a financial perspective? The other side of it is, what investments does it take, right? So not only do I have to think about the reimbursement side, but the cost that I have to put into managing a value-based payment contract, whether it be staff or infrastructure and the like. From a fiscal perspective, the one piece of advice I could offer is this something you can manage in your current fiscal reality? Some 50% of New York hospitals operate with negative operating margins, okay? They have a different consideration than those that don't operate with a negative margin. Do I have the patience to pull this off? And if I do have the patience to pull it off, what types of patients? Do I have the data? Do I have the staff to assess the data? Do I have the engagement of my staff?
I think you do need to know your data. You need to know where you stand today, and you need to know your capacity for change. And if you don't know your capacity for change, you need to dedicate some time to build it. And that nimbleness in this day and age is key to success.
I've seen a number of organizations that are in varying levels of readiness or preparedness to deal with value-based payments. And the one thing that those organizations that seem to be more successful in that area, they have incorporated this concept of value into their DNA as an organization. It's a mindset. It takes over from the top all the way down. Every part of the workforce is trained to deliver value, to make sure that the patients are satisfied.
First, understand your attributed lives and your patient population. Second, understand what your costs of care are, your quality measures. And then finally, once you have a firm grip on that and understanding on those items, really take a look at social determinants of health, how you're helping to coordinate care for those patients, how you're engaging those patients in their care management, what realistic goals are you setting up for them so that the patient is at the center of the care and is an integrated and an engaged part of that process.
I promise you that if you do not know where you're going to sleep tonight, making sure that you take your diabetes medication on time, in the right dose at the right time, not on your agenda. It's not. And it's not a value statement, it's a reality. These folks that are struggling, who are housing insecure, who lack security in their neighborhoods, who don't have access to good food, those types of insecurities in an individual's life will so complicate issues that it will impact their health. Their blood pressure is going to be out of control. Their diabetes is going to be out of control. They're not going to be able to have good mental health. And it all works together.
For example, my grandfather was really struggling before he passed. He wasn't cooking for himself. He was barely eating. He didn't like to drive anymore, so he was missing his doctor's appointments, and we didn't have a family support system designed to help him. Once we got that in place, and we as a family engaged with community resources as well as the provider, and we created that partnership, we were able to get him onto a better, more stable path instead of being in the ER multiple times. So again, drilling down when you have that high utilizer, and instead of just saying, oh, they're looking for attention, oh, this might be happening, really slow down and seek to understand and have that care management in place or that case management, engage with community-based organizations and find out what's happening.
I don't want to see value-based payment become another one of these things where it has a great name, it meant well, but in the end, there becomes a new set of words 5 years from now that again tries to capture the idea that high quality, right setting, right place, right treatment, aligned care is what people need, particularly for a population with chronic illness being served over time. We are still treating way too downstream when the population is far too acute. We're also seeing at the back end that the alignment needed for kind of discharge and keeping people from being readmitted is not really true alignment. Even in value-based models, that burden seems to fall mostly on the health systems, and it needs to not fall mostly on the health systems. It needs to be a shared obligation.
I think that we have to put our seatbelts on. I think we have to be prepared, and I think knowing your data and staying on top of your data and creating that internal resource capacity is absolutely essential this next year.
In our current state, our current delivery model and payment model is not sustainable. We have to change. Do I see fee-for-service still around in 5 years? I do. But it will be a decreasing percentage of overall payment. I do see an increasing amount of risk being brought on by practices, hospitals, and medical groups. What that will end up truly being, I don't know. But we do see today in New York City, in Buffalo, and everywhere in between, there are early innovators with various types of patient populations, Medicaid and not, that are really succeeding by changing up their approach to beyond just their four walls.
At some point, you're going to have to play. At some point, you're going to have to partner to be engaged in these models. And in that context, you thinking about it now from a fiscal perspective may be better than thinking about it after you're already engaged.
Value-based payments are not going away. They may change names. We may be talking about alternative payment models or some other payment structure, but the idea that we're going to be paying more for value and less for individual episodes of care is, I think, a concept that is that train has left the station.